Hello, and welcome to another in the diagnostic series here. In this particular video, I'm going to be discussing the Brief Psychiatric Rating Scale. Now, that's a rating scale for a number of symptoms, but key among the ratings of this is item 11 for unusual thought content, and that's the delusional disorder uh, item on the Brief Psychiatric Rating Scale. So the Brief Psychiatric Rating Scale should be conducted on every family in the family courts on item 11 to see if there's a persecutory delusion and to document the severity of that persecutory delusion when present, for the court's understanding, for treatment purposes, for everything. So let's take a look here at what the Brief Psychiatric Rating Scale is. So to begin with, let's just ground in what a persecutory delusion is. So this is from the American Psychiatric Association. This is a definition of a persecutory delusion. Persecutory type: delusions that the person or someone to whom the person is close is being malevolently treated in some way. And if you Google malevolent, it's having or showing a wish to do evil to others. So it's a fixed and false belief maintained despite contrary evidence. That's your delusion. Fixed false belief maintained despite contrary evidence that the child or them, these are being malevolently treated in some way when that's not true. Okay, they're not being malevolently treated. And what you will hear sometimes from the alive parent is they will extend their protection concerns surrounding the child into allegations of some sort of domestic violence in the past. It's clear that they believe they're being malevolently treated in some way by the targeted parent, even after the divorce, and they go back and talking about what happened back in the marriage. The child particularly will evidence this belief that they are being malevolently treated in some way. Okay, that the targeted parent has a wish to do evil to them, and so they will seek to flee from that parent. And so that's where I would refer you over to the video segment on assessing child abuse in the family courts and the one on assessing attachment pathology. A child seeking to flee a parent, a child rejecting a parent, is a disorganized attachment. The child has no organized strategy to bond to that parent. The cause of disorganized attachment is abusive or psychotic range parenting. Is the targeted parent abusive? If not, if you're not returning a diagnosis of child abuse relative to the targeted parent, then it switches over to the other. That's a path A, path B analysis. Since the only thing that causes the symptom, the only thing that causes a symptom of a child seeking to flee a parent, a child rejecting a parent, is abusive or psychotic range parenting. If it's not path A of the targeted parent being abusive, then it's path B of the allied parent who's the source of the child abuse and psychotic range parenting. That's the persecutory delusion. So there's your differential: child abuse here, psychotic here. Okay. And that should be for all cases where you see this symptom of a child seeking to flee a parent. Attachment pathology or attachment system and the strategies: insecure ambivalent, insecure avoidant, or disorganized or secure, form and stabilize around the age of 5. So if you see a suddenly emergent disorganized attachment towards a parent, that's a temporal indicator of child abuse having begun at that point, because that's the only thing that produces it. The child didn't show a disorganized attachment at 5, 6, 7, 8. All of a sudden at 9 or 10, they're showing a disorganized attachment. The child abuse started either by that targeted parent or by the allied parent who's gone psychotic, delusional thought disorder, because of the divorce situation. And so it's pretty clear. And when you're talking with the child, once you rule out, you get the some indicators. Why don't you want to be with the parent? You get reporting on the incidents. Conduct an applied behavioral analysis. That's the seminar on parenting, assessing parenting. If you don't know how to do that, go learn how to assess parenting. But when they give you these incidents, walk it through, do an applied behavioral analysis with the child, with the parent, about what happened. If there's abusive range parenting, report it to CPS or take appropriate protective action. If there's not abusive parent, boom, path A collapses and you're left with path B. Take a look at whether there's psychotic parenting. So you talk to the child and see if they have a fixed and false belief maintained despite contrary evidence that the parent has a wish to do evil to them. Okay, and that's so clear with the child as you're doing your child interviews, that the child believes that mom or dad, that targeted parent, has a wish to do evil to them. And they don't. You talk to the targeted parent, they're a normal range parent who just wants to give their child love. And the child's saying, no, don't love me because you're an inadequate person and whatever. And 5 years ago, something happened. That it's a persecutory delusion. And we need to start assessing that and documenting that, not only for our child protection response, but for the court's child protection response. So let's take a look now at the two variants of this pathology. Let's start with the narcissistic delusions. These are quotes from Theodore Milan, who is one of the grand experts in personality disorder pathology. He's created the Milan multi-axis scale for personality assessment. It's considered the gold standard for that. And these are quotes around the narcissistic delusion. Under conditions of unrelieved adversity and failure, divorce, narcissists may decompensate into paranoid disorders. Owing to their excessive use of fantasy mechanisms, they are disposed to misinterpret events and to construct delusional beliefs. Among narcissists, delusions often take form after a serious challenge or setback. Divorce has upset their image of superiority and omnipotence. Delusional systems may also develop as a result of having felt betrayed and humiliated. Divorce. Here we may see the rapid unfolding of persecutory delusions and an arrogant grandiosity characterized by verbal attacks and bombast. So we know for a fact that narcissistic personality disorders or personality pathology collapses into persecutory delusions under stress, like the stress of divorce and marital separation. So we should be doing an assessment for possible delusions, psychotic parenting from that allied parent that is inducing the disorganized attachment of the child seeking to flee from a normal range parent. Okay, we need to assess for that and document it, and document that we assessed for it. And what was our findings? Now let's talk about borderline delusions. Here I'll draw from Barno et al. They did a meta-analysis of all the psychotic range information around borderline personalities. And what they find here, Barno et al., this review reveals that psychotic symptoms in borderline personality disorder patients may not predict the development of a psychotic disorder, but are often permanent and severe and need careful consideration by clinicians. Therefore, adequate diagnosis and treatment of psychotic symptoms in BPD patients is emphasized. We therefore suggest that it is not a cognitive developmental deficit, but rather a tendency to construe interpersonal relationships as malevolent that characterizes borderline personality disorder, and this may be shared with certain psychotic disorders. What psychotic disorders? A persecutory delusion. So we know that the borderline personality will also collapse into persecutory delusions. The term borderline comes from the 1930s, when this category of personality was deemed to be on the borderline between neurotic and psychotic. So the term itself, borderline, carries the implication of potential persecutory delusions, potential psychotic. But it's not a schizophrenia type. It's not what a developmental deficit. It's trauma related. Okay, and it's just a tendency in their schemas and internal working models to see relationships as malevolent. So let's assess for a possible persecutory delusion. Path A, Path B, differential diagnoses for the child's symptoms. Okay, so you rule out child abuse by the targeted parent. That's the seminar in assessing parenting or assessing child abuse in the family courts. If path A collapses and there's no abuse, then we only have one explanation, path B, that we have the psychotic delusional disorder. So then you conduct an assessment for a delusional disorder. That's the seminar on assessing delusional thought disorders. Okay, so this needs to happen in all cases because we have child abuse as the only cause of the child's symptoms. So now let's take a look at the BPRS specifically. So if you go to Wikipedia, just go to Wikipedia and Google BPRS, Brief Psychiatric Rating Scale. And here's from Wikipedia. It says, the scale is one of the oldest, most widely used scales to measure psychotic symptoms. This is like your standard instrument that to use to document, to assess and document the potential presence of psychotic symptoms, including delusions. That's item 11 is on the delusions, and we'll take a look at that in a second. Now, if you scroll down the Wikipedia website, you will see the Brief Psychiatric Rating Scale Expanded Version 4.0 Scale Anchor Points and Administration Manual on ResearchGate. Okay, so then you click on that BPRS link. That will take you over to a site on ResearchGate where they have the Brief Psychiatric Rating Scale, and it's the article. It's by Ventura and Lukoff and Nectarline and Lieberman and Shaner, I believe. I used to work with these professionals. I was on Dr. Nectarline's project on schizophrenia. So I was trained for 12 years on the BPRS by Dr. Ventura and Lukoff, and as part of that project. So these Dr. Ventura and Nectarline were at my wedding. And so, you know, I know these. I've also spoken since then with Dr. Ventura and said, hey, I may be sending family court people over to you to get trained on the BPRS. So if anybody ever cares about actually assessing the pathology, you know, you can get a hold of Dr. Ventura and he'll train you, or you can listen to me, I'll train you. But we have the Brief Psychiatric Rating Scale there. Now, you'll notice you can download the PDF. In addition, if you just scroll down, it's just posted there. So you can just scroll on down and you'll see all the ratings for depression and anger and suspiciousness and, you know, just everything. Anxiety, all the 24 items are listed. Item 11 has to do with delusional thought disorders. So let's go to item 11 here, Brief Psychiatric Rating Scale. Unusual thought content. Here's what it says. Unusual thought content. Delusions are patently absurd, clearly false, or bizarre ideas that are expressed with full conviction. That's a critical piece here. Full conviction to this false belief. Now, how do we operationalize full conviction? They tell us, consider the patient to have full conviction if he or she has acted as though the delusional belief was true. In the family courts, yes, we have the child acting, avoiding the parent, acting as if they are in danger when they are not. That's full conviction to a false belief. Okay. Ideas of reference persecution can be differentiated from delusions in that ideas are expressed with much doubt and contain more elements of reality. So, on the key feature here, we're looking the ratings of 2 or 3 are normal range, elevations in the symptom, whatever the symptom is. So in this case, that's what they refer to as ideas of reference or ideas of persecution. The child may feel, you got an adolescent who feels their parents are being too strict, but there's going to be, that's going to be expressed with doubt and contains more elements of reality versus a delusional belief of a rating of 4 or higher. That is a fixed false belief. Now, how do we make that differentiation? The key element is, does the person have full conviction? Have they acted on the false belief as if it was true? So there's your beginning frame for that. Now, again, I was trained 12 years. The doctors Ventura and Lukoff, during the course of the year, would videotape their some of their interviews, and they would, on the reliability training, they would show us like 10 videos. They do the training, then they'd show us the 10 videos. We would have to rate the videos on all the BPRS items and reach a 90% reliability to their gold standard ratings. And so I've been trained on this. The key feature between a 3 and a 4 is full conviction. So let's take a look at the specific anchor points. 3, for mild. This is a mild, unusual thought. This would be considered the persecutory belief rather than a delusion. So it says the same as 2, but the degree of reality distortion is more severe, as indicated by highly unusual ideas or greater conviction. Content may be typical of delusions, even bizarre, but without full conviction. The delusion does not seem to have fully formed, but is considered as one possible explanation for the experience. So that's where you're looking. You're looking, does the child have full conviction? Does the parent have full conviction, the allied parent? Have they acted on the belief, the false belief, that the child is being malevolently treated in some way, that the allied parent, the targeted parent, has a wish to do evil to the child? Have they acted on that belief? That would be full conviction. If they have, it cannot be a rating of 3 because the rating of 3 is without full conviction. So the moment you get full conviction, you're in the higher, you're in a 4, 5, or 6 rating. So let's take a look at 4. There's a delusion present, but no preoccupation or functional impairment. This may be an encapsulated delusion or a firmly endorsed absurd belief about past delusional circumstances. So an encapsulated delusion is a limited scope one. So it's not about everything in the entire world. It's just one particular area. There's a fixed and false belief maintained despite contrary evidence. And that's what we have in the family courts. We have an encapsulated persecutory delusion directed specifically towards the targeted parent. Now, in the family courts, we do have preoccupation and we have large-scale functional impairment in the family relationship with the parent, okay, with the targeted parent. So it's higher than a 4 because we have functional impairment. So that makes it a 5, moderately severe. So look how fast we have reached a moderately severe persecutory delusion. We have full conviction, child acted on it, we have functional impairment. So with a full delusion present, with some preoccupation some areas of functioning disrupted by delusional thinking. So we have at least a moderately severe persecutory delusion. The question is how much functional impairment and preoccupation we have. If the child's worried about going to visit, the targeted parent gets stressed for days ahead of time or something, or seeks to avoid them or worry about them coming to school or their events or things, that's a whole lot of preoccupation. So that would kick it up from moderately severe to severe. Severe persecutory delusion. And if some areas of functioning, that the relationship with the targeted parent is clearly disrupted functioning in the family. But if they're having problems at school or any other additional problems anywhere, then that would functional impairment would increase to a 6. So either the preoccupation or the functional impairment will increase it. Let's take a look at 6. Full delusion present with much preoccupation or many areas of functioning are disrupted by the delusion. So in the family courts, as I look at the pathology of the child and the parent, and I called in sometimes to be a second opinion or to conduct an assessment, sometimes, on a situation, I will do a BPRS. I will rate the allied parent, I'll rate the child as to whether or not it's a fixed and false belief maintained despite contrary evidence, that the child has full conviction in it, the parent has full conviction in the child being malevolently treated in some way, that the targeted parent has a wish to do evil to the child when that's not true. And then it's not a 4 because there's functional impairment, so I've got at least a moderately severe. Occasionally, a lot of times, we get a severe. So let me stop for a second here to point out that based on a rating of the oldest, most widely used scale to measure psychotic symptoms, based on the symptom presentation in the family courts, it's a rating of a moderately severe to severe persecutory delusion that is not being diagnosed or even assessed by the mental health professionals in the family courts. That is deeply, deeply problematic when this persecutory delusion, and here's one of the reasons among many that it's deeply problematic. A shared delusion, an induced shared delusion, is a 2-person disorder. ADHD, autism, depression, substance abuse, eating disorders, all of those are one person. They're in a person. A shared or induced persecutory delusion is between 2 people. It's a social feature to it, and that has consequences. Because if the mental health person believes the shared delusion as if it was true, they become part of the shared delusion. They become part of the pathology because they have misdiagnosed a delusional disorder and believe it's true. Believe this persecutory delusion as if it's true. If you become part of the pathology and believe the delusion is true, and that pathology is the psychological abuse of the child by the allied parent, then you, the mental health person, become part of the child's psychological abuse. And this happens commonly with the child's individual therapists. They are not competent in the assessment of delusional thought disorders. They don't know what they look like. They're not trained in that. And they're just coming in to be supportive. Often low-level mental health professionals who are just doing the child individual therapy and Rogerian, they're trying to be very supportive and validate the child's feelings. You don't validate a delusion. No, that's not the treatment for it, but they didn't assess for delusion. And no one else is, so then no one's giving them the input that this is a persecutory delusion. So they become part of the delusional disorder. They believe it's true, and as a result become part of the child abuse of creating and validating a delusional thought disorder in the child because they're practicing beyond the boundaries of their competence. 2.01 APA Ethics Code. So that's the problem. In addition, If they're part of the pathology and they believe the share, they become part of the spousal abuse of the targeted parent, the psychological spousal abuse of the targeted parent, using the child as a weapon. So they become, the mental health professional becomes an abuser, a child abuser and a spousal abuser, because they're practicing beyond the boundaries of their competence. If they were simply required to generate a BPRS rating on item 11, then they could say, oh no, this is a true belief that the child is being malevolently treated, and they would need to document that. Okay, so tell us what the documentation is that you believe this is child abuse by the targeted parent, that the targeted parent has a wish to do evil to the child and is out to cause him harm. Document that up and say it's not a delusion. Because if it's not true, then the child has full conviction. Boom, they're up to a 4. Some functional impairment, they're up to a 5. A lot of functional impairment, preoccupation, they're at a severe persecutory delusion. Okay, so everybody should be doing this just to double check as to what the pathology is. They're not. They're practicing beyond the boundaries of their competence. So with that, I'm going to wrap up my discussion about the Brief Psychiatric Rating Scale. There are other scales or items that could be included, such as anger, anxiety, depression, the sadness, suspiciousness, whatever seems relevant, of the 24 items, you can add those to. But specifically, oh my goodness, the delusional thought disorder, for the sake of the court, for the sake of mental health clarity, for the sake of diagnostic accuracy, conduct a brief psychiatric rating on the family dynamics, on the child's delusion, on the parent's delusion. Document what you think it is. It's up on the internet. Go to Wikipedia, boom, click it. There it is. Okay. I've been trained for 12 years on this, the diagnostic reliability to the authors. You don't have to. Okay. Just do it. Just do it and see what you come up with. Okay. You don't need to be diagnostically, vetted for this. Just give us the rating on that. Otherwise, you're not competent to work with delusional thought disorders. If you don't know how to assess for delusional thought disorders, you're not competent working with delusional thought disorders. If you're not competent in how to assess and diagnose attachment pathology, you're not competent to be working with attachment pathology. So the mental health people need to kind of up your game a little bit and deal with the pathology and assess the pathology that you're working with. So with that, that's the close of my discussion on the Brief Psychiatric Rating Scale here.